Today we'll be talking about the latest dyslipidemia guidelines that has been published from the European Society of Cardiology in 2019. Our agenda for this lecture will be fourfold: risk assessment and stratification for patients with dyslipidemia, what will be the intervention strategies, used for this group of patients, the treatment targets and drugs that you should use to reach these targets, and we'll discuss in brief some special groups that you will meet in your practice. First of all, what we study dyslipidemia for. The studying of lipid pathogens treatments aims primarily at the prevention of atherosclerotic coronary artery disease. This will eliminate and minimize the impact of the disease and the related disabilities to the patients. In the general population, this could be achieved by promoting healthy lifestyle in the first place. Individual lives by tackling unhealthy lifestyles, and this by reducing increased level of cardiovascular risk factors such as LDL cholesterol and blood pressure. So you first aim at eliminating the risk factors, and you aim to prevent the disease rather than treating. Primary prevention is mainly the first step. So you have to assess the risk for your patient. The guidelines states that the total risk estimation should be used by a dedicated scoring system, like the score, which is adopted by the European Society of Cardiology. And this is adopted at patients more than 40 years of age without evidence of cardiovascular disease, who are not diabetic or not have chronic kidney disease and not have familial hypercholesterolemia, or if you cannot apply the risk score assessment if the LDL cholesterol is more than 190. It's recommended that the high and very high risk individuals are identified on the basis of the risk factors already that they had, which is diabetes, renal diseases, very high levels of individual risk factors. Familial hypercholesterolemia is considered also one of the very high risk individuals. It's recommended that such patients are considered as a priority for advice and management of all risk factors. Risk scores developed for the general population are not recommended for risk assessment in patients with diabetes or familial hypercholesterolemia, as we stated before. And this is the SCORE cardiovascular risk chart that is used to estimate the 10-year risk of fatal cardiovascular disease. And these charts are made for low-risk regions of Europe, high-risk regions of Europe. And this one is for the high-risk regions of Europe. And as you can see that you can use according to the age groups. You can calculate. You can mention the age of the patient, then plot his age and calculate his risk score according to other risk factors. 40 years old. This patient who is 40 years old, his risk score is similar. He is a smoker patient. He's 40 years old. His risk score is very similar to a non-smoker patient with 65 years of age, and this is what we call the atherosclerotic the vascular age of this patient. Risk score screening, including the lipid profile, should be considered, as we said, in patients more than 40 years of old if they are males, and in women more than 50 years of age or postmenopausal. The charts available are categorized for regions with high cardiovascular disease mortality and for low cardiovascular disease mortality in Europe. However, in Egypt, when applying risk assessment chart, you have to know that these risk score charts are underestimate the atherosclerotic cardiovascular disease risk here in Egypt. You have to put in mind that there are other factors rather than the risk score assessment that modify the cardiovascular disease risk. Certain individuals who are at high or very high cardiovascular disease risks that will be discussed later, just as diabetic, familial hypercholesterolemia, as we have said, and chronic kidney diseases, who have carotid plaques and calcium scoring more than 100 or extreme lipoprotein E elevations. These are considered a high or very high cardiovascular disease risk groups. These calculators are available on websites that you can calculate the risk scores for your patients. The risk modifiers for these calculators, you have to put in mind that social deprivation may cause cardiovascular disease also, patients who are obese, or central obesity, patient who has increased body mass index, who has a metabolic syndrome, all could modify the risk for cardiovascular disease. Physical inactivity also modify the risk. Psychosocial stress, including vital exhaustion, if the patient has family history of premature cardiovascular diseases, which is defined as men less than 55 years of age and women less than 60 years of age with cardiovascular disease, are also risk modifier. Chronic immune-mediated inflammatory disorders modify the risk for these patients. Major psychiatric disorders, treatment of HIV infection, AF, LVH, chronic kidney diseases, all are these factors that modify the risk for the patients to develop cardiovascular disease, cardiovascular disease. Beside the score risk assessment score, there are classification for the risk of the patient to develop cardiovascular or cerebrovascular diseases. It's categorized into four strata: very high risk, moderate, and low risk. The patient with very high risk score are those with either documented atherosclerotic cardiovascular disease. Documented includes previous ACS, MI, or unstable angina, patient with stable angina already diagnosed, patient with coronary revascularization before who received PCI or CABG, patient with stroke or transient ischemic attack, and patient with peripheral arterial disease. All these patients are considered to have or to be very high risk scores. Patient with diabetes mellitus with target organ damage already, or at least 3 major risk factors other than diabetes, or patient with early onset of type 1 diabetes mellitus more than 20 years are considered very high risk. Severe chronic kidney disease are considered also a very high risk by itself. If the patient, you calculate his score was more than 10% for 10-year risk of fatal cardiovascular disease, is considered a very high risk. Also, familial hypercholesterolemia with atherosclerotic cardiovascular disease or with another major risk factor. So, patient with documented atherosclerotic cardiovascular disease by themselves are considered a very high risk. With diabetes, patient with risk score more than 10, and familial hypercholesterolemia. Patients with high risk are those markedly elevated single risk factor, which may be the total cholesterol more than 310, LDL more than 190, or their blood pressure is more than 180 or 110. Patient with familial hypercholesterolemia without other major risk factors. If the patient has a familial hypercholesterolemia with other major risk factors, he is considered as a very high risk group. Patient with diabetes mellitus without target organ damage or with diabetes duration more than 10 years or other additional risk factor. Moderate chronic kidney disease, or if you calculate the score for this patient by a score chart, and it was found to be more than 5% and less than 10% for 10-year risk fatal cardiovascular disease. This is considered as high risk group. The moderate risk group are young patients, type 1 diabetes mellitus less than 35 years, or type 2 diabetes mellitus less than 50 years with diabetes duration less than 10 years, without other risk factors, or if you calculate their score, it was between 1% and less than 5%. This moderate risk. The low risk group are the calculated score less than 10% for 1%, for 20-year risk of fatal cardiovascular disease. These are the risk stratification for the patients. So, according to the risk you have calculated to the patient, according to his risk factors, what will be the intervention you have to do for this patient? First of all, you have to do laboratory assessment. The laboratory assessment according to the guidelines are as follows. Total cholesterol is to be used for estimation of total cardiovascular risk. First, you have to assess the total cholesterol. HDL cholesterol analysis, LDL cholesterol analysis, triglyceride analysis. These are the lipid profile you have to assess for the patient. Non-HDL cholesterol evaluation is recommended also, particularly in patient. If you find the patient with high triglycerides, or was diabetic, or obese, or very low LDL, you have to assess the non-HDL cholesterol. The apolipoprotein B analysis is recommended for risk assessment, particularly in people with high triglycerides, also diabetes, obesity, or with metabolic syndrome, or if you do LDL and it was very low. This could be used as an alternative for LDL cholesterol as the primary measurement for screening, diagnosis, and management. Okay, so the ApoB analysis could be used for risk screening, diagnosis, and management for patients with very low LDL cholesterol. As a class 2A, you have to do lipoprotein little a even once in person lifetime. And the very high lipoprotein little a considered more than 180 milligram per deciliter. Okay, the lipoprotein little a should be considered in selected patient with a family history of premature cardiovascular disease. So if you have a patient with premature cardiovascular disease, family history of this, you have to do lipoprotein. You may find his lipid profile is very normal, no diabetes, no smoking, and so. But if you do lipoprotein little a, you may find it very high. According to the risk for those patients, according to the lipid profile, how would you manage those patients? Arm is the primary prevention and the secondary prevention. The primary prevention for patients with low risk, moderate, or moderate risk, patients with high risk and very high risk group. What to do in each group? Patient with low risk, according to the level of the LDL cholesterol, you will do the intervention you propose for this patient. In patient with low risk, you only start drug intervention if the LDL cholesterol is more than 190. Okay, you have to start drug management. In patient with moderate risk, which the score is 1% to less than 5%, you may start medical treatment, adding to interventions and adding to lifestyle modification, if not controlled, at levels of 100 to less than 116 milligram per deciliter of LDL cholesterol. But also mandatory to start drug treatment if the patient has LDL cholesterol more than 180. Okay. High risk. Patient with high risk, for primary prevention, you may add drug if the life intervention is not, or lifestyle modification is not proven effective, if the LDL cholesterol is less than 100. But it's mandatory to start treatment by whatever drug you choose for those patients with high risk, whose LDL cholesterol between 100 and less than 116. Okay, in patient with very high risk, you start early drug intervention, drug treatment, if the LDL cholesterol between 70 to less than 100. Okay, and if it is less than 70, you may add drug if the lifestyle modification intervention is not working with them. This is for primary. For secondary prevention, these patients already considered as a very high risk group. Patient with secondary prevention already known to be very high risk because they have developed atherosclerotic cardiovascular disease. And these patients, you start medications in spite of the LDL level. However, if the LDL level is less than 55, you may postpone drugs a little bit if the lifestyle intervention keep this level as it is, or you may add a drug if you would like. So, what according to the guidelines would be the targets? First of all, you have to assure for the patients to push the patient to do these maneuvers. First of all, to stop smoking. Any smoking should be stopped. Healthy diet, low in saturated fat with a focus on whole grain products, vegetables, fruit, and fish. You have to encourage the patient for physical activity, almost 3.57 hours moderate vigorous activity per week, or 30 to 60 minutes most days. يعني تخلي البيشنت يمشي مثلا ماشي عادي 30 ل 60 دقيقة في اليوم. His target body mass index should be between 20 to 25, and waist circumference may be should be kept less than 94 in men and less than 80 for women in Caucasian patients. The blood pressure targets should be less than 140 over 90. For the LDL cholesterol, the patient with very high risk, either in primary or secondary prevention, your target is 50% LDL reduction from baseline, and a goal of less than 55 milligram per deciliter. In patient with high risk group, you have to achieve at least 50% reduction or LDL cholesterol less than 70 milligram per deciliter. This is for high risk patients. For moderate risk, LDL goal less than 100. For low risk patient, LDL target less than 160 milligram per deciliter. The non-HDL cholesterol as a secondary goal should be between 85, 100, and 130 milligram per deciliter in patients with very high or moderate risk people. Okay. The apolipoprotein B secondary goals are In patient with very high risk score should be less than 65 milligram per deciliter. In patient with high risk score should be less than 80, and in patient with moderate risk score should be 100 milligram per deciliter. The triglyceride is not the primary goal for intervention for cardiovascular disease prevention, but its goal may be kept less than 150 milligram per deciliter. If the patient is diabetic, you have to keep his hemoglobin A1C less than 7%. And this is a recommendation for the treatment goal in LDL cholesterol. In secondary prevention, patient at very high risk, LDL, as we have said, that 50% reduction from at least 50% reduction, or goal less than 55 milligram per deciliter. For patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, not necessarily the same time as the first event, while taking maximum tolerated statin dose, you could decrease their LDL cholesterol less than 40 milligram per deciliter. Okay, so in patients with established cardiovascular disease, you decrease the LDL cholesterol less than 55 milligram per deciliter. But if the patient on this target develop another attack of cardiovascular disease, you have to decrease his LDL cholesterol to less than 40 milligram per deciliter. Drugs intervention, it's recommended to prescribe high intensity statin up to the highest tolerated dose to reach the goals. Okay, if the goals are not achieved with maximum tolerated dose of statins, you have to combine ezetimibe, and this is class 1B. For primary prevention patients at very high risk, but without familial hypercholesterolemia, put this into brackets, without familial hypercholesterolemia, if the LDL target is not achieved on maximum dose of statins and ezetimibe, you can put a PCSK9 inhibitor. Okay, and this is 2B, class 2B. Okay, so ezetimibe is considered a class 1A, class 1B to be added to statins if not achieve the target, and PCSK9 inhibitors in patients without familial hypercholesterolemia could be added or should be added to statins if not achieved. In patients with very high risk and for primary prevention, not achieving goal or maximum tolerated dose of statin and ezetimibe, combination with a BCSK inhibitor is recommended. So for primary prevention, something, but for secondary prevention, if you want to achieve the target on very high risk patients, you have to add PCSK9 inhibitors as early as possible. And this is class 1A, is different from the previous one. For very high risk patients, that is with atherosclerotic cardiovascular disease or with another major risk factors, who do not achieve their goal on maximum tolerated dose of statin and ezetimibe, a combination with PCSK9 inhibitor is recommended. It's class 1C. Okay. If a statin-based regimen is not tolerated at any dose, even after rechallenge, ezetimibe alone should be considered. Again, if a statin-based regimen is not tolerated at any dose, a PCSK9 inhibitor added to ezetimibe may be considered. So the statin, if it is not tolerated, you can add PCSK9 inhibitor to ezetimibe. If the goal is not achieved, a statin combination with a bile acid sequestrant may be considered. So this is the place where the drugs have been put inside for the guidelines for the management of dyslipidemia. What are these drugs? We'll discuss briefly the drugs. First, the statins. These reduce the synthesis of cholesterol in the liver by inhibiting the enzyme HMG-CoA reductase, hydroxymethylglyceride-CoA reductase. This promotes the increase of the LDL receptors expression at the surface of the hepatocytes. When you increase the LDL receptors on the hepatocytes, this increases the uptake of the LDL from the blood, so decrease the level of the LDL cholesterol inside the blood. Its effects, according to the trials, that they decrease the LDL by 50% in the high intensity groups, or 30 to 50% in moderate intensity doses. They decrease the triglycerides by 10 to 20%. They increase the HDL by 1 to 10%, and they have some sort of pleiotropic effects that has been proposed as an anti-inflammatory and an antioxidant. This is beside their dyslipidemic or change in lipid profile. What we call high-intensity statins, moderate-intensity statin, low-intensity statin. What are these? The high-intensity statin therapy, according to the randomized control trial and according to the FDA approval. Atorvastatin and rosuvastatin are the only drugs they considered as a high-intensity statin therapy, which by definition could decrease the LDL cholesterol by approximately more than 50% from its baseline. The dose of atorvastatin is 80 milligram and the dose of rosuvastatin is 20 milligram. This dose, the 40 milligram, is not approved yet but could be used. Drugs moderate intensity statin are by definition that lowers the LDL cholesterol from 30 to 50% from baseline. These drugs are atorvastatin at a dose of 10 milligram, rosuvastatin as a dose of 10 milligram, simvastatin as a dose of 20 to 40 milligram, bravastatin at a dose of 40, lovastatin at a dose of 40, fluvastatin XL at a dose of 80 milligram, and this drug is not approved by the FDA. Fluvastatin 40 milligram at 40 milligram dose twice daily, and this is a dose approved for the fluvastatin by FDA. Pitavastatin is a 2 to 4 milligram per day, and this drug by its dose is not approved by the FDA. Okay, the bold drugs are approved by the FDA. The low intensity statins that by definition could lower the LDL on average by less than 30%, and this is the simvastatin as a dose of 10 milligram, bravastatin as a dose of 10 to 20 milligram, lovastatin as a dose of 20 milligram, fluvastatin as a dose of 20 to 40 milligram, and the pitavastatin as a dose of 1 milligram. Again, the drugs who are in bold are those approved by the FDA. The other drugs are not approved, but could be used on clinical grounds. The major adverse effects for the statins are as follows. First, myalgia, myopathy, or rhabdomyolysis. That's what we call the statin-associated muscle symptoms, SAMS. Okay, rhabdomyolysis is defined as muscle necrosis with creatine kinase more than 10 to 40 upper limit of normal. This is number one. Number two, the increase in the liver transaminases. And it's considered clinically significant if it's more than 3 times the upper limit of normal. These drugs have been claimed that they increase the risk of new onset diabetes mellitus, but it's dose dependent and has been reported in patients that has already been with the glucose intolerance or in patients with family history of diabetes. I mean, it helped in the new onset of diabetes, but this was clinically irrelevant in most studies. In high doses, statins can cause proteinuria. They have various drug interactions with the drugs that metabolize by cytochrome B450. The most important and the very annoying side effect for these drugs are the muscle symptoms. What to do for the muscle symptoms if it occurred for the patient? The guidelines propose this algorithm. If these muscle symptoms is attributed to the statins, you have to assess by as follows. First, if it's symptomatic muscle symptoms and the creatine kinase is less than 4 times upper limit of normal, creatine kinase more than 4 times upper limit of normal, or if the patient has already rhabdomyolysis. If the patient is symptomatic and creatine kinase times upper limit of normal, you have to wait 2 to 4 weeks. You stop the statin and wait 2 to 4 weeks. If the symptoms persist, although you stop the statin, you give a statin again and check for other cause of muscular symptoms. Okay, but after 2 to 4 weeks, if the symptoms improves, so you give another statin rather than the first one at usual or at a lower dose. If the symptoms reoccur again after re-challenging the statin, low dose third effective potent statin, use another potent statin with alternate day after day, I mean, or once or twice weekly dosing regimen if the patient has symptoms again. Okay. If the patient has already developed, if the patient has creatine kinase level more than the 4 times upper limit of normal, you can stop for 6 weeks and then re-administer another potent statin. Okay, but the target is to use the LDL goal with maximum tolerated dose of the statin. Okay, if you achieve this target with maximum tolerated dose and still the patient has symptoms of some muscle symptoms, you add ezetimibe. Okay, You can add ezetimibe on top of statins, or you stop statins at all and add the ezetimibe by itself, either by using it it's by itself or by adding a PCSK9 inhibitor. So you give a very low dose of statin, very low dose of statin, and use an ezetimibe to achieve the goal. If still you cannot achieve the goal by low dose of statin and ezetimibe, you can add a PCSK9 inhibitor or adding a bile acid sequestrant. Okay, this according to the level of significant recommendations that we have stated before. But if the patient cannot tolerate statins at all, you can use ezetimibe by itself, as we have stated before in the level of recommendations, and use ezetimibe by itself or by adding PCSK9 inhibitor or by adding also bile acid sequestrant. Okay. The next drug that used in the treatment of dyslipidemia is the ezetimibe. The ezetimibe inhibits the uptake of dietary and biliary cholesterol at the level of the brush border of the intestine by interacting with the Niemann-Pick C1-like protein 1. This inhibits this protein, thus prevents the reuptake of the cholesterol. When added to the statin, it decreases the LDL cholesterol by 20 to 27%, increases the HDL by 3%, and decreases the triglycerides by 8%. Its adverse effects are very, very low, and no clinically significant adverse effects. It adds the prescribed dose of 10 milligrams per day. The next drug are the bile acid sequestrants. Binding the bile acids, they bind the bile acid, preventing the reabsorption of both the drug and the cholesterol into the blood, and thereby removes a large portion of the bile acids from the enterohepatic circulation. When they are given, added to statins, they decrease the LDL by 18 to 25%. They increase the HDL by almost 0%. They have no effect on the HDL and may increase the triglyceride in some patients, and this is one of the adverse effects of these drugs. The doses: cholestyramine 24 gram, solistopol 20 gram, cholecalciferol, which is a synthetic type of bile acids, is 4.5 gram. This drug, the last one, is most tolerated than the previous two. Okay. Its adverse effects is some sort of GI disturbances. They decrease absorption of some vitamins, and we propose that treatment of the GIT disturbances by giving very low dose at start and give the drug with ample amount of fluid, and then increase the dose gradually of the drug so that the patient cannot develop GIT disturbance. The next group of drugs, which is very important and has been newly added to the guidelines due to its profound effect on familial hypercholesterolemia, treatment of familial hypercholesterolemia, or in treatment of increased LDL cholesterol in patients with atherosclerotic cardiovascular disease, is the PCSK9 inhibitors. They decrease the plasma level of the PCSK9. This interaction triggers the intracellular degradation of the LDL cholesterol receptors. Okay, that increase expression of the LDL receptors at the cell surface and therefore induction of circulating LDL cholesterol levels. What does it mean? It means that the PCSK9 by itself destroy the LDL receptors inside the cell. So when you inhibit this PCSK9, you increase the expression of the LDL receptors at the cell surface, thereby increase the uptake of the LDL cholesterol from the plasma, decreasing its amount. Its effects: it decreases the LDL cholesterol by 60%, and when added to statins, they decrease it by 73% from its baseline. It may increase the HDL by 9%, decrease the triglycerides by 26%, and it has been also reported that they decrease the lipoprotein little a by 30 to 40%. The two approved drugs, the alirocumab and the evolocumab, are both approved for once every 2 weeks or once per month subcutaneous injection. The major adverse effects that has been reported for these drugs are itching at the site of injection, flu-like symptoms. They have been claimed some muscle symptoms when combined with statins, and the most important thing is that they are very costly and not cost effective in some countries, and also for some patients you cannot give these drugs. Another drug that used, which is the lumetabide, that inhibit the macrosomal triglyceride transfer protein, thus prevents the formation of very low density lipoproteins in the liver and of chylomicron in the intestine. It's mainly used in homozygous familial hypercholesterolemia. This drug is used in homozygous familial hypercholesterolemia. In the trials, it decreases LDL by almost 50%, and it has some sort of adverse effects in increasing the aminotransferase levels, some GIT disturbances, which can be tolerated over time by using the drug. This drug has been used in homozygous. The mipomersin is an antisense oligonucleotide that able to bind the messenger RNA of ApoB100, which triggers the selective degradation of mRNA molecules, preventing the translation of ApoB protein, reducing the production of atherogenic lipids and lipoproteins, including LDL and lipoprotein LDL. Which means that when the protein is not synthesized well, the production of the lipids will be decreased. The ApoB protein is targeted by this mipomersin by destroying its messenger RNA. Thus, this protein is not formed, and then the production of the lipids will be decreased. It's also only indicated in homozygous familial hypercholesterolemia, some adverse effects that itching at site injection, some liver toxicity, and steatorrhea has been reported. Next drug is the fibrates. The fibrates have been known for a long time, I know, and they act by agonists of peroxisome proliferator activate receptor alpha, PPAR alpha, acting via transcription factor, regulating, among other things, various steps in lipid and lipoprotein metabolism. Their main effects are on triglycerides by decreasing it by 50%, either fasting or non-fasting levels of triglycerides. They increase the HDL by less than 20%. They decrease the LDL by less than 20%. Some adverse effects have been reported for fibrates, like the skin rash, GIT disturbances, myopathy, which is less than fenofibrates, more with the canfobrizol, increase the liver enzymes, and some cholestasis. The omega-3 fatty acid acts by poorly understood mechanism. Till now, the mechanism of action of omega-3 fatty acid on regulation of the lipid is not known, but may be related to their ability to interact with the PPARs and to decrease secretion of ApoB proteins. The main effect by decrease the triglyceride by 45%. The icosapentaenoic acid and docosahexaenoic acid doses are 2 to 4 grams per day. Their adverse effects are GIT disturbances and may increase the propensity for bleeding when used with aspirin, clopidogrels, and so. And also the cost. Till now, they are available, but they are somewhat costly. Some other drugs that have been mentioned in the guidelines and also are not being used widely, the nicotinic acid, which inhibits the diglycerol acetyltransferase 2, resulting in decreased secretion of very low density lipoprotein particles, which is also reflected in reduction in plasma level of both intermediate density lipoproteins and LDL particles. There has been no beneficial effects and an increased frequency of serious adverse effects by these drugs on cardiovascular disease patients. The CETP inhibitors may induce an increase in HDL cholesterol by more than 100% on dose-dependent basis. One of the drugs that has been used in the trials, the anacetrapib, reduced major coronary events by 9% of a median follow-up of 4.1 years. Okay, this anacetrapib is one of the cholesterol ester transferase protein inhibitors that has been only tested in patients with coronary artery disease. The bempedoic acid is an oral small molecule that inhibits cholesterol synthesis by inhibiting the action of ATP citrate lyase. This reduces LDL cholesterol by 30% and by about 50% if combined with ezetimibe in diabetic patients. Okay, and those are the drugs that has been used. But what to do to monitor the patient first at the start of the treatment and on follow-up? How often you will test the lipids? This, according to the guidelines, before starting lipid-lowering drug treatment, you should do a baseline lipid profile. At least two measurements should be done with an interval 1 to 12 weeks, with the exception of conditions where concomitant drug treatment is suggested. such as acute coronary syndromes and very high risk patients. Okay, how often do you test the lipids afterwards? 8 weeks plus or minus 4 weeks after start treatment, 8 weeks plus or minus 4 weeks after adjustment of treatment until the goal is achieved. Okay, how often should lipid be tested once the patient has achieved the target? So when you reach the target, you can measure the lipid only once per year. Okay, what about the liver enzymes? When to measure the liver enzymes? First, you make a baseline liver enzymes, so before treatment. Once after 8 to 12 weeks after starting treatment, routine control of ALT thereafter is not recommended during statin treatment unless symptoms suggesting liver disease evolves. Drug treatment with fibrates, control of ALT is still recommended. Okay, so when you're using statin alone, you should not do ALT frequently, but if you are using fibrates, you have to do ALT frequently. What if the liver enzymes become elevated? If the ALT is less than 3 times upper limit of normal, continue the therapy and check the liver enzymes in 4 to 6 weeks. Okay, in which patients should hemoglobin A1C should be checked. Regular check for hemoglobin A1C should be considered in patients only if they are high risk of developing diabetes and on a high dose of statin. Groups to be considered for glucose control are the elderly and the patient with metabolic syndrome, obesity, and other signs of insulin resistance. So these group of patients who you should test the hemoglobin A1C in these patients on a statin therapy. If the alanine transferase is more than 3 times upper limit of normal, okay, if you are following up the liver enzymes and the ALT is more than 3 times upper limit of normal, you stop the lipid-lowering therapy or reduce dose and recheck liver enzymes within 4 to 6 weeks. Cautious reintroduction of therapy may be considered after ALT has returned to normal. If the ALT remains elevated, check for other reasons. So this is how to manage the patient with elevation of liver enzymes. What about the creatine kinase? We've seen the proposed algorithm for management of muscles. But how often should you test the CK enzyme? Before starting therapy, if baseline CK is more than 4 times upper limit of normal, do not start drug therapy and recheck after this. Then monitor. Routine monitoring is not necessary. Just only check if the patient developed myalgia. Okay. Quickly, we can go through the special groups slide for each one. In patients with hypertriglyceridemia, statin treatment is recommended. It's a first drug of choice for reducing cardiovascular disease risk when the triglycerides more than 200. In high risk or above patients, triglyceride between 135 to 499 milligram deciliter by statin treatment. Omega-3 fatty acids could be added in combination with the statin. In primary prevention, patients who LDL cholesterol and triglycerides more than 200, you can add a fenofibrate consider in combination with statin. In high-risk patients who are LDL cholesterol goal, but the triglycerides more than 200, the fenofibrate may be considered in combination with a statin. Okay. In women, this group of patients are very peculiar. Statin treatment is recommended in prevention of atherosclerotic cardiovascular disease in high-risk women. Statin are recommended for secondary prevention in women as in men. Okay, but in pregnancy, the lipid-lowering drugs should not be given in pregnancy. If the pregnancy is planned during pregnancy or during the breastfeeding period. However, severe familial hypercholesterolemia patients, bile acid sequestrants, which are not absorbed, and or LDL apheresis may be considered. So if the pregnancy is planned during pregnancy or during breastfeeding period, do not give any lipid-lowering drugs. Some recommendations for the bile acid sequestrant, but you can do plasma apheresis for the patients with familial hypercholesterolemia. In patients old age more than 65 years, treatment with statin is recommended as class 1A with people with older people with atherosclerotic cardiovascular disease in the same way as younger patients. Treatments with statin is recommended for primary prevention according to the level of risk in older people aged less than 75 years of age. Initiation of statin treatment for primary prevention in older people aged more than 75 may be considered if at high risk or above. It is recommended that the statin started at low dose if there is significant renal impairment and or potential for drug interaction, and then titrated upward to achieve LDL cholesterol goals. It means that in older patients, you start low and go slow. Do not push the patient towards the drug. In diabetic patients with type 2 diabetes at very high risk, an LDL reduction of at least 50% from baseline and LDL cholesterol goal less than 55 milligram per deciliter is recommended. In patients with type 2 diabetes at high risk, LDL reduction at least 50% from baseline and LDL cholesterol goal of less than 70 milligram per deciliter is recommended. Statins are recommended in patients with type 1 diabetes who are at high or very high risk category. You have to intensify the statin therapy when before introduction of a combination therapy. You have to reach the maximum tolerated dose. However, if the goal is not achieved, you add ezetimibe as class 2A. Statin therapy is not recommended in premenopausal patients with diabetes who are considering pregnancy, as we have said before, or not using adequate contraception. Statin therapy may be considered in both type 1 and type 2 diabetes patients aged less than 30 years of age with evidence of end organ damage and LDL cholesterol more than 2.5 millimole per liter as long as pregnancy is not planned. In patients with acute coronary syndrome, in all ACS patients without any contraindication, you should give high dose statins. The lipid levels should be less than 55 milligram per deciliter or aiming a reduction of 55% from baseline. If LDL is not achieved after 4 to 6 weeks with maximum tolerated statin dose, combine with ezetimibe. So you wait for 4 to 6 weeks and test for the target. If the patient is not at target, you add an ezetimibe. Patient with acute coronary syndrome. In patients with acute coronary syndrome, if the LDL cholesterol is not achieved after 4 to 6 weeks, despite maximum tolerated dose of statin therapy and ezetimibe, you can add PCSK9 inhibitor. In patients with confirmed statin intolerance, in whom a statin is contraindicated, ezetimibe should be considered by itself alone. For patients who are present with an ACS and whose LDL cholesterols are not at goal, despite already taking a maximum dose of statin and ezetimibe, adding a PCSK9 inhibitor early after the event, if possible, during hospitalization, for example, should be considered. In patients undergoing PCI, you can pre-treat or load the patient, with high-dose statins undergoing PCI for an NCS or elective PCI. So this is class 2A in the European Society of Cardiology guidelines to pre-treat or load the patient with statins. In patient with chronic kidney disease, recommended that the patient with kidney disease outcome quality stage 3 to 5 CKD are considered to be very high, at high or very high risk of atherosclerotic cardiovascular disease. The use of statins or statin ezetimibe combination is recommended in patients with non-dialysis dependent stage 3 to 5 CKD. In patients already on a statin ezetimibe and or a statin ezetimibe combination at the time of dialysis initiation, continuation of these drugs should be considered. In patients with dialysis dependent CKD and free of atherosclerotic cardiovascular disease, commencing statin is not recommended. So if the patient has no atherosclerotic cardiovascular disease and is dialysis dependent, do not give statins. Patient with peripheral arterial disease and patient with valvular heart disease. Only 2 recommendations, and these are the last recommendations. In patient with peripheral arterial disease, lipid-lowering therapy, including a maximum tolerated dose of statin plus ezetimibe or combination with PCSK9 inhibitor should be given to reduce the risk of, because these patients are considered as high risk for developing atherosclerotic cardiovascular disease. In patients with severe aortic stenosis and senile aortic valve stenosis, they should not be given lipid-lowering treatment aiming at decreasing the progression of the aortic valve disease. However, if the patient has other indications for statin, they may be given lipid-lowering drugs. But to give a lipid-lowering treatment so as to decrease the progression of the disease is not recommended. Thank you very much.